That's the Grand Canyon with the Colorado River running through it. That's in Arizona. It's not in Utah. It's not in Nevada. And it's not in Colorado. It's in Utah. That's my disclosure slide. That's some saguaro cactus outside. In case anybody thinks that Arizona is nothing but a desert, that's a ski area at about 10,000 feet just north of Phoenix. So I am going to talk about various methods of endovenous ablation, including tumescence, which is RF and laser. No tumescence, chemical ablation, physician compounded foam or varithena, and mechanochemical or the Clarivein, and finally tumescence, no tumescence and no sclerosing with the cyanide acrylate. All right, so the indications of any of these methods is for treatment of the great, small, or accessory incompetent saphenous veins, the vein of Giacomini, cranial extension of the small saphenous, saphenous and non-saphenous tributaries, and persistently incompetent perforators. I think it's mandatory for complete elimination of all the sources of superficial venous insufficiency, and it must include something like endothermal or chemical ablation of the incompetent accessory saphenous or major tributaries, persistently incompetent perforators, and incompletely ablated veins. So now I'm going to move on to the tumescent modalities, VenaFit and vein close. VenaFit is the closure fast method. There's lots of literature, including 5-year results. With the vein close, there's no literature support. They rely on the closure fast data. As far as lasers, we've kind of moved from the lower wavelength lasers up to the higher wavelength lasers, primarily so that you target water in the vein wall, which leads to fewer perforations and therefore fewer side effects. This is a nice study from actually 10 years ago now, where they compared the 980 bare fiber to the 1470 radio fiber and came up with the conclusion that the diffusion of the laser energy results in more diffuse vein wall damage, fewer perforations, and therefore fewer complications. Where not to treat, I don't treat below the knee with a thermal ablation. I worry about the risk of paresthesia, but particularly those patients who have dysesthesia, something that's painful. That's a very unhappy patient. I don't treat the most proximal portion of the small saphenous vein, again, because of motor nerve injury. Tortuous tributaries can be handled. You may have to use shorter segments, and perforators is technically more difficult, and that closure RF catheter is cumbersome. Some contraindications to endovenous ablation: acute venous thrombosis, either deep or superficial; active skin infection, whether it's close to the site or remote; significant arterial insufficiency. You may need that vein as a conduit later on; uncontrolled medical illnesses, deep venous obstruction; and a very thin patient. If you treat a very thin patient with a very superficial vein, that cord, that sclerotic cord, is going to bother them for a long period of time. There are some contraindications, including pregnancy, limited mobility, although that may be, if you don't have a choice, you need to, that may be the best method. A tortuous vein, you can use a guide wire or multiple puncture sites. Previous thrombophlebitis, small saphenous, or small vein, can really consider a foam sclero, and inability to wear compression hose. Venous Seal is perfect. Now moving on to the non-tumescence, the MOCA device. Some indications, same as any other endovenous ablation method. Anything straight, even some tortuous, because you can guide that wire. It's angled just a little bit, and you can treat the intrafascial or even extrafascial veins, and you can go all the way to the ankle because there's no risk of nerve injury with this method. There are some advantages. Again, you can go below the knee and treat those extrafascial, and you can treat those C5 and C6 patients, again, all the way to the ankle. Contraindications: previous superficial venous thrombosis. That wire will snag on those synechia, and you'll do a stripping in a very short period of time under no anesthesia. Large veins, probably better left to some of the other methods. Non-tumescence, non-sclerosant. That is, in fact, a real place on a corner in Winslow, Arizona. For those of you who are old enough to remember that. So Venous Seal, some indications: Any superficial truncal vein, great saphenous, small saphenous, anterior accessory, posterior accessory. Perforators are off-label. Any portion of the truncal vein can be treated. There are some contraindications, particularly those people who have an allergy to cyanuracrylate used for fingernails and eyelashes. And an immunocompromised patient is probably not the one that you want to use adhesive. There have been reported some inflammation, reported 15 to 25% in the literature, and in our V-Close trial it was around 16%. As you gain experience, and there's a technique that Kathy has developed with Kathy, I learned it from Kathy, which is to resheath that delivery catheter. So you put, before you pull it out, you put the sheath back over the top of the delivery catheter and then pull it out. That seems to have really diminished, and I believe Kathy has told us in the past that she has, her incidence is now about 1% of that inflammatory response. We do use some anti-inflammatory drugs in the procedural period. Looking at the 36 to 60 months of the V-Close trial, comparing RF to cyanacrylate, one of the important things was we didn't see any hypersensitivity reactions between 12 and 60 months. So one of the concerns was maybe this could be a long-term problem. It doesn't seem to be at all. So conclusions, not every endovenous ablation modality will be appropriate in every situation. I think you need to have one tumescence, one non-tumescence, and one non-tumescence corrosive in your armamentarium. I think ultimately what you and the patient are most comfortable with is what you want to use. I would provide a word of caution that proximal truncal ablation alone will ultimately fail. And I think unless you're committed to careful follow-up and adjunctive treatment, both the practitioner and the patient will be left with unsatisfactory results. Thanks very much, and we'll move on to the next slide.